run through my slides that I've created for you for this week. So here we go, geography and health. So a couple of the things we'll be talking about is epidemiology, accessibility, geography of disease, and the geography of care. So no discussion of geography and health would be complete without talking about Dr. Snow's cholera map. So Dr. John Snow suspected that there was something in the water when the cholera outbreak occurred in London in the 1850s. And so remember, this was before the germ theory. This was before we realized that, germs were out there and that they could cause problems. And so he created this map and showed where cholera outbreaks were occurring and was able to determine that it wasn't something in the air, and which is what most people thought, but instead it was something in the water. And so he created this map and then was able to kind of use that to go, hey, look, the cholera seems to be located in areas that have this particular pump. And so I want to show you this short TED video that talks about that map. And while you're watching it, I want you to think about how these questions.
If you haven't ordered yet, I generally find the If you haven't ordered yet, I generally find the rigatoni with the spicy tomato sauce goes best with diseases of the small intestine. So sorry, it just feels like I should be doing stand-up up here because of this setting. No, what I want to do is take you back to 1854 in London for the next few minutes, and tell the story in brief of this outbreak, which in many ways I think helped create the world that we live in today, and particularly the kind of city that we live in today. This period in 1854, in the middle part of the 19th century in London's history, is incredibly interesting for a number of reasons, but I think the most important one is that London was a city of 2.5 million people, and it was the largest city on the face of the planet at that point, but it was also the largest city that had ever been built. And so the Victorians were trying to kind of live through and simultaneously invent a whole new scale of living, the scale of living that we now call metropolitan living. And it was, in many ways, at this point in the mid-1850s, a complete disaster. They were basically a city living with a modern kind of industrial metropolis with an Elizabethan public infrastructure. So people, for instance, just to gross you out for a second, had cesspools of human waste in their basement, like 1 foot to 2 feet deep. And they would just kind of throw the buckets down there and hope that it would somehow go away. And of course, it never really would go away. And all of this stuff basically had accumulated to the point where the city was incredibly offensive to just walk around in. It was an amazingly smelly city, not just because of the cesspools, but also the sheer number of livestock in the city would shock people, not just the horses, but people had cows in their attics that they would use for milk that they would kind of hoist up there and keep them in the attic until literally their milk went out and they died, and then they would kind of drag them off to the bone boilers down the street. So you would just walk around London at this point and just be overwhelmed with this stench. And what ended up happening is that an entire kind of emerging public health system became convinced that it was the smell that was killing everybody, that was creating these diseases that would kind of wipe through the city every 3 or 4 years. And cholera was really the great killer of this period. It had arrived in London in 1832, and every 4 or 5 years another epidemic would take 10,000, 20,000 people in London and throughout the UK. And so the authorities became convinced that this smell was this problem. We had to get rid of the smell. And so, in fact, they concocted a couple of early, kind of founding public health interventions in the system of the city, one of which was called the Nuisances Act, which they got everybody, as far as they could, to empty out their cesspools and just pour all that waste into the river. Because if we get it out of the streets, it'll smell much better. And, oh, right, we drink from the river. So what ended up happening, actually, is they ended up increasing the outbreaks of cholera because, as we now know, cholera is actually in the water. It's a waterborne disease, not something that's in the air. It's not something you smell or inhale. It's something you ingest. And so one of the founding moments of kind of public health in the 19th century effectively poisoned the water supply of London much more effectively than any modern-day bioterrorist could have ever dreamed of doing. So this was kind of the state of London in 1854. And in the middle of all this kind of carnage and offensive conditions, and in the midst of all this kind of scientific confusion about what was actually killing people, there was a very talented, classic 19th century multidisciplinarian named John Snow, who was a local doctor in Soho in London, who had been arguing for about 4 or 5 years that cholera was in fact a waterborne disease, and had basically convinced nobody of this. The public health authorities had largely ignored what he had to say. And he'd made the case in a number of papers and done a number of studies, but nothing had really kind of stuck. And part of what's so interesting about this story to me is that in some ways it's a great case study in how cultural change happens, how a good idea eventually comes to win out over much worse ideas. And Snow labored for a long time with this great insight that everybody kind of ignored. And then on one day, August 28th of 1854, a young child, a 5-month-old girl whose first name we don't know, we know her only as Baby Lewis, somehow contracted cholera, came down with cholera at 40 Broad Street. You can't really see it in this map, but this is the map that becomes the central kind of focus in the second half of my book. So in the middle of Soho, in this working class neighborhood, this little girl becomes sick. And it turns out that the cesspool that they still continue to have, despite the Nuisances Act, bordered on an extremely popular water pump, local watering hole that was well known for the best water in all of Soho, that all the residents from Soho and the surrounding neighborhoods would go to. And so this little girl inadvertently ended up contaminating the water in this popular pump. And one of the most terrifying outbreaks in the history of England erupted about 2 or 3 days later. Literally 10% of the neighborhood died in 7 days. And much more would have died if people hadn't fled after the initial kind of outbreak kind of kicked in. So it was this incredibly terrifying event. You had these scenes of entire families dying over the course of 48 hours of cholera alone in their one-room apartments, in their little flats. Just an extraordinary, terrifying scene. Snow lived near there, heard about the outbreak, and in this amazing kind of act of courage went directly into the belly of the beast because he thought an outbreak that concentrated could actually potentially end up convincing people that, in fact, the real menace of cholera was in the water supply and not in the air. He suspected an outbreak that concentrated would probably involve a single point source, one single thing that everybody was going to, because it didn't have the kind of the traditional slower path of kind of infections that you might expect. And so he went right in there and started interviewing people. He eventually enlisted the help kind of this amazing other figure who's kind of the other protagonist of the book, this guy Henry Whitehead, who was a local minister, who was not at all a man of science, but was incredibly socially connected. He knew everybody in the neighborhood. And he managed to track down, Whitehead did, many of the cases of people who had drunk water from the pump or who hadn't drunk water from the pump. And eventually Snow made a map of the outbreak. He found increasingly that people who drank from the pump were getting sick, people who hadn't drank from the pump were not getting sick. And he thought about kind of representing that as a kind of a table of statistics of people living in different neighborhoods, people who hadn't, percentages of people who hadn't. But eventually he hit upon the idea that what he needed was something that you could see, something that would take, in a sense, a higher level view of all this activity that had been happening in the neighborhood. And so he created this map, which basically ended up representing all the deaths in the neighborhoods as black bars at each address. And you can see in this map the pump right at the center of it. You can see that one of the residents down the way had about 15 people dead. And the map is actually a little bit bigger. As you get further and further away from the pump, the deaths begin to grow less and less frequent. And so you can see this kind of something poisonous kind of emanating out of this pump that you could see in a glance. And so with the help of this map and with the help of kind of more kind of evangelizing that he did over the next few years and that Whitehead did, eventually, actually, the authorities slowly started to come around. It took much longer than sometimes we like to think in this story. But by 1866, when the next big cholera outbreak came to London, the authorities had been convinced, in part because of this story, in part because of this map, that in fact the water was the problem. And they had already started building the sewers in London. And they immediately went to this outbreak and they told everybody to start boiling their water. And that was the last time that London has seen a cholera outbreak since. So part of this story, I think, while it's a terrifying story, it's a very dark story, and it's a story that continues on in many of the developing cities of the world. It's also a story, really, that is fundamentally optimistic, which is to say that it's possible to solve these problems if we listen to reason, if we listen to the kind of wisdom of these kinds of maps, if we listen to people like Snow and Whitehead, if we listen to the locals who understand what's going on in these kinds of situations. And what it ended up doing is making the idea of large-scale metropolitan living a sustainable one. When people were looking at 10% of their neighborhoods dying in the space of 7 days, there was a widespread consensus that this couldn't go on, that people weren't meant to live in cities of 2.5 million people. But because of what Snow did, because of this map, because of the whole series of kind of reforms that happened in the wake of this map, we now take for granted that cities of 10 million people, cities like this one, are in fact sustainable things. We don't worry that New York City is going to collapse in on itself quite the way that Rome did and be 10% of its size in 100 years or 200 years. And so that, in a way, is the ultimate legacy of this map. It's a map of deaths that ended up creating a whole new way of life, the life that we're enjoying here today. Thank you very much.
All right. So when we talk about disease and we talk about geography and health, one of the things that comes to mind is diffusion. So we talked about diffusion when we were dealing with movements of people. So disease diffusion refers to how the disease gets from the source into a new area. And it's well documented that disease is likely to be affected by distance. So there's what we call a distance decay. As you get further away from the source of the disease, the less likely you are to contract it. And this can be seen in this graph, which shows the number of AIDS-related AIDS rates falling further away from the source of San Francisco. And it's superimposed over a typical contagious disease spread. And so in our increasingly connected, integrated transportation system, it is suggested that disease can spread quickly via roads on a national scale or airports on a global scale. And of course, we'll end this discussion today talking about COVID. But there are two common types of disease diffusion, which is classified as expansion and relocation. So expansion occurs when the disease spreads from one place to another. And this disease often intensifies in the originating region. And as it expands into new areas, it's likely to weaken. And this type of diffusion was recently recognized as the swine flu, which had its source in Mexico. And then relocation diffusion is the spatial spread pattern, just like when we talk about relocation diffusion of ideas and culture, that the disease leaves an area in which it originates and it moves into a new area. And an example of that is like HIV or measles, or the spread of cholera in Haiti back in 2010. And that was thought to have been brought by aid workers from Nepal in response to the earthquake that they had. And it's quite common to see a mixture of the two types of disease diffusion. And this diagram, of course, shows that the mix of that expansion and relocation. There's a really cool article in the British Geographer that talks about the spread of disease and the management. And when you get the slides, you can click on the link. When we deal with infectious disease, the number one, like, most prominent thing that's going to impact the spread of that is going to be poverty based. Okay, so the next type of disease that we talk about is chronic disease. Chronic disease is more like heart disease and cancer, diabetes, things like that. Is it contagious? Not usually, unless you're talking about, I guess you could say that cancer might be considered contagious, but it's more of a environmental type situation, pollution. If you talk about the thing that happened in Hinckley and the cancer rates, or the DuPont thing, or the Flint, Michigan thing. So as you get away from those areas, or even the cholera outbreak in London that we talked about first, you see, as you get further away from those water holes, there was less disease. And so that's not really a chronic, that's an infectious disease. So I'm sorry, I shouldn't have brought that up. So anyways, so also, in order to really kind of talk about disease, you need to understand the difference between an epidemic and a pandemic. So an epidemic is, it's spread to multiple countries. It's a large number of people within a community or population. And a pandemic, as you should all be aware now, is when it spreads to multiple countries or continents across the world. So one example of a pandemic is the influenza virus. It emerges with different seasonal viruses that only affect humans, but it can also cause disease and affect human transmission and things like that. So the first big pandemic is the Spanish flu back in 1917. It killed some 17 to 50 million people worldwide over about a year between like 1918 and 1920. It's one of the most deadly pandemics in human history, not to be confused with our coronavirus situation now. So then we get into the H2N2, which replaced the 2018 Spanish flu pandemic. It caused about 1.1 million deaths worldwide, about 116,000 people in the US in 1957. And then in 63, there was another one. This was what they called the Hong Kong flu. That caused about another 1 million people to die. And then there was the swine flu in 2009, which killed about, 500,000 people or something like that in the first year. And so those are like the four main pandemics before COVID. So now let's look at this map here. So this is flu virus. So you can look at the seasonal flu virus in the US. So you can see that DC currently has a very high level of flu over the last week. So we can look at last year because let's not look at last year. Last year was not a very big flu situation because of COVID, believe it or not. So there wasn't a lot of flu back then last year because most people were staying home and staying away from each other. So this is a flu view, and you can actually look at the various weeks of the year. So you can see why we call it a seasonal flu. So this is in 2019. And going into 2020, this is February 15th, February 29th, March 7th. Now we're going to hit COVID. And so it should start going away. Look at how quickly it diminishes, right? But also we're coming into, June and July, which you don't have a lot of flu typically then. So then you get July, you get another little bump there. And so, it's just an interesting little app if you're interested in that. Okay. So malaria is another infectious disease. It kills more than 1 million people worldwide. It was nearly eradicated in the 1950s, but recently it's become resistant. So it has evolved, as many viruses do, because they change and reproduce so quickly. They're able to kind of become resistant through genetic variation. So the question is why, if it's killing 1 million people worldwide every year, is there so little press? And here's one of the main reasons. So if you look at the map of malaria and malaria cases, you can see maybe why we don't really talk about it. And that's because it hits areas that are lower income, high levels of poverty, access to healthcare, which are all things we're going to be talking about today. So some of the challenges associated with malaria is it's what we call a multi-stage disease. So it's got a variety of stages. So it's got like the infectious stage, which they call the exoenterocytic cycle. And so there's the stage where you have it and it's not causing any problems, and then you have a stage where it's causing problems, and you transmit the virus, and then there's another stage. And so that's the first one. There's all these different stages to it. It's not like, hey, I've got the flu, I'm going to stay in bed. It's once you get malaria, it never goes away. You have it in your body forever. So then you just take drugs all the time, so that you don't, so you're not going to transmit it anymore, but it's still there. The other thing is that it's considered a parasitic infection. Its vector is a mosquito. A lot of it deals with the environment. So in areas where there are mosquitoes versus aren't mosquitoes. And it typically is going to impact poverty areas, as I already showed you in the map. So this is one of the pictures of an area, which is why we have environmental issues associated with malaria. So again, you have lots of water, particularly stagnant water, with mosquitoes. You've got poverty. poor housing, things like that. It's hard to believe that there was a time when every state in America except Alaska had malaria. There's a long history of malaria in the US dating back to the 15th century when it first appeared, until today, where it still affects some local residents. Malaria parasites have existed longer than humans have. It likely originated in Africa with fossilized mosquitoes. First known case of the disease in America is said to be shortly after Columbus got here in 1492. He was infected with this disease during his voyage. Although the mosquito itself died off in colder climates. In the 1600s, it established itself and became an epidemic in the Jamestown settlement of colonies. And Western settlers and their slaves transmitted the disease to Native Americans, which then quickly spread it to Maryland and Georgia and areas of Alabama and Florida. So this is a map from the, I want to say 1800s, that kind of shows where malaria is located. It wasn't until the 1906, during the construction of the Panama Canal, that the spread was recognized as a problem, when about 21,000 of the 26,000 people who were working on the creating of the Panama Canal actually got infected with malaria. They're like, oh, maybe we should, consider that this is a problem. So around the same time, a whole bunch of US soldiers were deployed to malaria endemic. Endemic means found only there. During World War II, were infected with the disease. So it was believed that about 60,000 soldiers died from the disease while fighting in Africa and the South Pacific, which then, of course, ramped up our campaign in the US to fight and, prevent malaria. And that's when the military started using DDT, which controlled both malaria and a bacterial disease known as typhus. And it wasn't just the slaves or the poor or the soldiers who contracted the disease. It said that George Washington, Abraham Lincoln, and Ulysses S. Grant all had malaria. By the 1950s, it was effectively eliminated in the US because we were able to, kill off essentially the mosquitoes and deal with the environmental factors that contribute to malaria progression. Although the CDC reported about 63 outbreaks in the US between the 50s and 2011 or so. But these are cases that are thought to be local and said to be from people who contracted the virus from somebody who traveled to an endemic area of, so imagine, you've got like an aid worker and they go to, I don't know, somewhere in Africa and they get malaria and they don't know, and then they come back here and a mosquito bites them, and then that mosquito then bites somebody else, and so now you have this, situation in which you've got malaria still existing. So in the US, there's about 1,000, maybe 2,000 people who report malaria annually. Most of them have traveled to an infected region. So the 4 ways it was kind of reduced is via electricity. So we're using lights, and we're able to, kill the little mosquitoes. Steam power. So we're able to and screens. And so the screens, like a mosquito net to keep your bed safe, because they bite at night when it's dark. So, oops. All right. So an interesting thing is the Center for Disease Control, which we hear about all the time. The CDC recommends, wearing masks and getting vaccinated and doing this and doing that and taking anti-malarials and, getting vaccinated for this, that, and the other. Was created in 1946, and it opened its doors in Atlanta, and its primary mission was simple yet very challenging, and that was to prevent malaria from spreading across the nation. They had less than 400 people that worked there, and they took root in the South, which was known to be the heart of the malaria zone in Atlanta, Georgia. And the guy who started it was kind of like this big advocate for public health issues. And he pushed for the CDC to extend its responsibilities to other diseases. And so it's kind of like the legacy of the Center for Disease Control. They did like disease surveillance, and they did like obviously campaigns for using screens and DDT, and nowadays wearing masks, or getting vaccinated, or washing your hands and all that good stuff. So the CDC is one of the major operating components of the Department of Health and Human Services. It's the premier health promotion, prevention, and preparedness agency. But it had its, my little quote, preventing malaria from spreading across the nation since 1946. That's my little, I was trying to be cute. All right. So DDT, it was developed as the first of modern synthetic insecticides back in the 1940s. It was initially used with great effect to combat malaria and typhus and other insects because it's really, really, really good at killing insects. It intercepts their DNA reproduction. It really, really kills bugs. It was really, really good, and so I'm going to show you this movie, this short video, so that you can kind of see what it's about and kind of the environmental issues associated with it. So let's just watch this video.
For the Public Health Service to take a closer look at this?
Yes, and I know that they already are. I think particularly, of course, it's Miss Carson's book, but they are examining the matter.
If you think of her as a revolutionary, it's rather startling.
So sorry, I forgot to say, Rachel Carson in 1962 created a book that talked about, it was called Silent Spring, which really kind of awakened the US public to concerns over the dangers of improper pesticide use. And it led to eventually, she's like the mother of the environmental movement, essentially. What she realized is that although DDT was really great at killing pests, it also had all of these toxicological issues. And so her book was called Silent Spring. So that's why they're calling this Silent Spring.
But in the sense of a change in our thought, I think she was revolutionary.
Rachel was my mother too, after my mother died.
real threat, then, to the survival of man is not chemical, but biological, in the shape of hordes of insects.
They're spraying DDT. Look at how people are just like hanging out on the street, eating their lawn, being sprayed in the pool.
All the pieces of an extremely complex jigsaw puzzle are at last falling into place. It is now possible to build up a really damning case.
Silent Spring are gross distortions of the actual facts, completely unsupported by scientific experimental evidence and general practical experience in the field.
Particularly, of course, Miss Carson's book, but they are examining the matter.
No one in either county farm office who was talked to today had read the book, but all disapproved of it heartily.
Miss Carson maintains that the balance of nature is a major force in the survival of man, whereas the modern chemist, the modern biologist, the modern scientist believes that man is steadily controlling nature.
Now, to these people, apparently the balance of nature was something that was repealed as soon as man came on the scene. Well, you might just as well assume that you could repeal the law of gravity. The balance of nature is built of a series of interrelationships between living things and between living things and their environment.
I hit the escape key. I forgot. Sorry. All right. So DDT, which is dichlorodephanyl tetrafluoride or tetraethane, sorry, is known to be very persistent in the environment. And it bioaccumulates, which means that the bugs have it, and then the things that eat the bugs, and then the things that eat the bugs who eat the bugs. And so it just accumulates, it doesn't go away. It kind of, so, you know, yes, it kills one bug, but then, you know, a lizard eats that, you know, 100 bugs a day, and all of that 100 pieces of DDT are then picked up by a bird, and then that bird is eaten by, you know, for example, bald eagles were on the significant decline because of DDT. It's persistent in the environment. It's still in the environment. it's not water soluble. So a lot of things are broken down by water and made less effective. Essentially, they're diluted. Not the case with DDT. It can travel long distances in the upper atmosphere. Yes, we have discontinued its use, but the concentration in the environment is still there. I mean, there's still DDT out there, but because of the residues that have been left behind. But I love this, DDT is good for me. So there was a little song back, and it was just crazy. I remember as a kid, they used to spray malathion. They would, like to get rid of fruit flies. Mediterranean fruit fly was a big deal in California in the 70s and 80s. And so there would be, malathion spray over on certain days. And so, you'd go out and there'd be like this residue on your car. But they literally just fly over the suburbs and spray them with malathion. It's just crazy. Anyways, so when we talk about cancer, which again is a chronic disease, is there a pattern? So this is kidney cancer. So we could argue that, yes, there seems to be a lot of people in the Midwest that suffer from kidney cancer. And so a lot of our diseases are one of those things that maps really help us to explain what's going on and to better understand. This is lung cancer in males. So this is skin cancer. So melanoma is known to be caused by the sun, exposure to the sun. So where there is more sun exposure, you should have more, skin cancer. They believe that skin cancer can also be correlated with race and lactose intolerance. So if you're lactose intolerant, you're more likely to get skin cancer, things like that. This is showing you the most common cancer. So if you're going to have cancer, lung cancer in the United States is the highest, and prostate cancer is very high in Africa, Central Africa. Just kind of an interesting. So talking about the role of culture. So are certain cultures more likely to expose you to cancer? California is looking to ban menthol cigarettes and menthol cigarette advertisements, which are predominant in African American communities. And although African Americans are on the low end of cigarette smoking in the United States, the menthol, which is said to make it easier to inhale the toxic chemicals into your lungs because menthol has like this numbing effect. So menthol cigarettes were targeted to African American folks. Advertisements, so the Marlboro Man, was this big Western guy who wore a hat, but the menthol man was an African American. They also put a lot more billboards and things like that in African American communities for menthol cigarettes rather than just regular cigarettes. So there's this whole thing that's been talked about, which I think is kind of interesting. So how healthy people are in a country or a state or a neighborhood is critical and very complicated. There are various measurements of, well-being, which we call health metrics. And one could use these to compare the physical and or emotional well-being of a person or groups. Things that combine several measures are known as a health index. And the most useful type of health metric for a group of people is called the health index. So this is the Bloomberg Global Health Index scores for 169 countries. And the top 10 healthiest countries in the world are highlighted. So the US, you know, but Japan is the healthiest. Japan and Iceland. Oh no, Spain, look at how high Spain is. So we're at 73. That's the lowest. We just barely made the top 10. But experts disagree about what factors are most important to include in a health index. So like, and what sort of factors should be included? Should it include poverty or war? Should, you know, should it just be about, you know, life expectancy and things like that? So one of the most useful health metrics is infant mortality rate, which is the number of children who die during their first year of life per 1,000 live births in that region. So you can see that we're at a little less than 1%, but looks like the Canadians and the Australians are in that, you know, less than 0.5%. Another health metrics is life expectancy. How long can you expect to live? Japan has the highest life expectancy of any country in the world. Some of the things that impact life expectancy in Africa are like AIDS, sanitation issues. Calculations are largely based on observed death rates plus other stuff, but life expectancy, of course, can be impacted by tons of things, outbreaks of disease. So this is a lot to do with malaria and AIDS. They still have AIDS situations in Africa, definitely have malaria problems in Africa. And then there's the Ebola was a big thing, still is in Africa. So, and then the geographical variation in death and disease can also be attributed to something we call the geography of healthcare. And some of that has to do with how much money a country spends on, you know, prenatal care, postnatal care, and the number of, you know, kids that a woman has. A lot of poor individuals will have premature babies, or they'll have low birth weight, which in turn invites a whole bunch of other illnesses, most notably, of course, infant death. Poor children also continue to suffer from poor diet, access to regular health care, which of course is going to shorten your life, reduce your capacity to be productive citizens, all that good stuff. And high percentages of physically or mentally disabled citizens are found in some of the poorest areas of the United States. So this is a plot map that shows healthcare expenditure versus the gross domestic product. So how much money the country makes versus how much they spend. So we're way up here. So this is what we call a trend line. So healthcare expenditures per capita is very high. But look at how much they spend in this is their per capita. This is how much money the country makes. This is how much they spend in healthcare. So we spend the most versus Qatar. They have a lot of money, but they don't spend a lot of money. So yeah, so it's kind of interesting. And then of course, access to healthcare is defined as having an adequate supply of services to help people maintain or improve their health. These can be things like primary care providers, hospitals, emergency services. And of course, that's going to be impacted by things like socioeconomics, like affordability, health literacy, like do people know that they need to, you know, for example, women should have their, you know, annual pap smear at the age of 45, you need to do this, and at the age of 55, you need to do that, things like that. So we call the lack of access to medical facilities a healthcare desert. And there were 6 key services that a particular study in the United States did. And so they looked at access to pharmacies, primary care providers, hospitals and hospital beds, trauma centers, and low-cost healthcare. And nearly 8.4 million people live in counties with at least 4 of the 6 types of healthcare deserts. So lack of access. So here you see a map. 40% of the counties are pharmacy deserts, where most people have to drive more than 15 minutes to reach a nearby pharmacy. GoodRx estimates that over 41 million Americans live in a pharmacy desert. We here in Southern California, not so much. South Dakota, Montana, Nebraska, Kansas have the largest number of counties that suffer from a lack of having a pharmacy. So while they may have access to a provider to get the prescription, to get that filled, it may be a little more complicated. On average, healthcare provider deserts have 1 full primary care provider for every 10,000 people. So a potential patient caseload over 3 times the recommended level. So in total, about 13 million people live in a primary care provider desert. This would be Orange County here. Gray is good. Blue is bad. Green is okay. So it goes from green to blue. So 9% of all the U.S. counties have live in a primary care provider shortage area. As with healthcare provider deserts, many hospital deserts are located in rural areas. So like in Vermont, there's only 1 healthcare center in one county in Vermont. That's this one right here. There's only 1 in the entire county. There's 1 hospital. So it's also true that hospitals tend to operate where the economic conditions are favorable. So there are a lot of hospital deserts are located in low-income neighborhoods. A few years ago, I think it was in 2007, King Drew Medical Center in Los Angeles was shut down due to poor patient care. And that is in a predominantly African-American area. It served predominantly African-Americans and Hispanics, Latinx people. And they shut it down. I mean, it was a bad facility. For the most part, you were probably, had a 50-50 chance of dying going there, but at least you had access. And now you have to go much further in order to get access to medicine. So about 80 million people don't have access to enough hospital beds. And then, of course, trauma centers, which is, every second counts. Doctors often refer to what we call the golden hour, which is the concept that a patient needs to receive care within an hour of their injury in order to increase their chances of survival. 40% of the counties in the US live in a trauma care desert. That means they have to drive more than 60 minutes to get to the nearest trauma center. So nearly 49 million people live an hour or more away from a hospital. And of course, look at all these in Montana and, North Dakota, and Idaho, Wyoming, Nevada. The nice thing about this area in Nevada is there aren't a lot of people that live here, which is probably another reason why they don't have a trauma center, is there aren't a lot of people. So you're going to build a huge, level 1 trauma center. in an area where, the statistical likelihood that you'll have need for such a thing is there. And then federally funded community health centers are especially critical in underserved communities. In 2019, nearly 30 million people visited one of these low-cost health centers. And of those, about 91% were at or below the federal poverty level. Just about half of them were enrolled in Medicaid or Children's Health Insurance Program. About 25% didn't have any insurance. 5% of those people were homeless. 31% were children. And 63% of the 30 million people that access these low-cost health areas, health facilities, were in ethnic minority groups. So again, this means you have to drive more than 20 minutes to get to an affordable primary care place. So in Texas has the largest, highest uninsured population in the country. About 18% do not have access to health insurance. So kind of crazy. So it also looked at how healthcare deserts are more likely to occur where residents have, again, lower incomes, less insurance coverage, and also, believe it or not, internet access is considered access to healthcare, because nowadays, especially now, like I haven't seen my actual doctor in person in 2 years, and yet I've had nice Zoom conference calls with them. So the major recognition of health disparity began about 2 decades ago with a Surgeon General's report in the early 2000s that documented disparities in tobacco use and access to mental health care by race and ethnicity. And so for decades, overall improvements in health over time have persisted, and in some cases gotten even worse. And so if we look at, how we look at the various, ethnicities in the United States. So as you can see, so this is showing you what the colors mean. So this is health and well-being. So, they're 19% worse here. They're 5% worse in like education and literacy. 7% worse in healthcare systems, so quality of care, health coverage, stuff like that. And if you've listened to the news or seen anything, you know that people of color have had a higher rate of infection and hospitalization and death due to COVID-19. And as of 2018, life expectancy among Black people was 4 years lower than white people, with the lowest expectancy among Black African-American men. It also documents disparities across other factors. Low-income people are even worse. So if, in addition to that, if you are, LGBTQA, you also experience a certain number of health challenges at an increased rate. And this has only gotten worse for all of these communities since COVID-19. So the year 2020 has really been illuminating a lot of the important differences in what we call the geography of vulnerability. So people across the US experiences of COVID-19 and the many societal stresses exacerbated or directly resulting from the pandemic. Our understanding of the geographic spread of COVID-19 was largely based on national scale epidemiological models, which was place-based response to community level impact. So what that means is every county got to decide how they were going to deal with the rules about, wearing masks, not wearing masks. And so geographers have really kind of stepped up, in my opinion. We've done a lot of work looking at integrating local and population scale research, and but it's still very rare. And so I have two clips in my lecture here this week. I'm not going to play them now, that I want to encourage you to watch. They're both about 10 minutes apiece, but they talk about the context of geography mapping and the vulnerable populations and how we might be able to use geography and the geography of healthcare, which is the topic for this week, to really address some of these critical disparities across the United States. So those are those two. And so just to review, infectious disease means it's transmitted from person to person, or sometimes from an animal like a rat or a mosquito to other people. These are also known as communicable diseases versus non-communicable diseases, which are also known as chronic disease, heart disease, stroke, cancer. So what's the difference? Most chronic diseases affect people over a longer period, therefore they affect older adults, versus infectious diseases, which may affect anyone, but are more likely to kill people who are poor or already unhealthy or are children. So one of the interesting things that we might be able to correlate without causation, with COVID-19 is, in addition to the racial disparity, there's certainly an economic disparity, meaning the more money you have, the less likely you were to A, get COVID, or B, die from COVID, because you have access to medicine, you can stay home for weeks at a time, and you can order Postmates or have your food brought in, where people who do not have access to those types of things don't. They live in larger communities, which means more access. They had to go to work, all that good stuff. But in addition to that, people who were already unhealthy. My father, who had diabetes, was not severely overweight, but he was overweight. I mean, he wasn't like super obese. He was also very old. Died from COVID back in December. And it really, in my opinion, I looked at it from a geographic perspective, that if we look at correlation without necessarily causation, because I haven't done a study, but a lot of the people who, especially early on, were dying from COVID had some underlying health issue, diabetes, heart disease, things like that, in addition to age, because there were lots of other people at my dad's facility who were just as old, if not older, who did not, even though they got COVID, didn't die from COVID. So just kind of an interesting idea that, these infectious diseases are more likely to kill people and impact people who are poor or already unhealthy, or our children, because kids have lower immunities, I guess. Thank you. Have a nice week.